We're recording.
We're ready to go?
We're ready to go.
All right, thank you. And hello, everyone, and welcome to Research Ride, a journey from idea to implementation of research programs in the Department of Medicine at Emory University. I am your ride leader, Charlie Searles, and a faculty member in the Division of Cardiology and the Associate Vice Chair for Research and Space Management in the Department of Medicine. Today, we are very excited to be touring with Dr. Carlos del Rio, a physician scientist and public health scholar who is the chairman of the Department of Medicine at Emory and a global expert in HIV research and policy. Dr. Del Rio is the H. Cliff Sauls Distinguished Professor of Medicine at Emory and also a professor of global health in the Rollins School of Public Health, where he was actually a department chair for 10 years at one point in his career. Among his other titles, he is the co-director of the Emory Center for AIDS Research, otherwise known as CFAR, and he's the International Secretary for the National Academy of Medicine. He has had numerous other academic leadership positions, too numerous to name in this short podcast, as well as awards at all institutional, national, and international levels. And he has served on dozens of scientific review and advisory committees. His bibliography contains close to 600 original articles, reviews, and book chapters. And finally, Dr. Del Rio has made hundreds of appearances in English and Spanish media where he has been sought out for his comments related to a variety of public health topics. Welcome, Dr. Del Rio. Carlos.
Happy to be here, Charlie.
Thanks again. Can you start off by telling us a little bit about how you would describe your research and how you got into this field of study?
So let me just say that I never necessarily trained to be a researcher. I, in a way, kind of stumbled upon research. I think research has always been, I've always had an inquisitive mind, and being inquisitive and being scholarly, I think, is one thing, and then going into research is a separate one. From early on in my training, even before I started residency, I was working in at the end of medical school in Mexico, you have to do what's called a year of social service, and part of my social service was working at a hospital in Mexico, and I was in charge of believe it or not, I was in charge of the enteral nutrition program, and I was in charge of essentially doing mixtures to put in people's through feeding tubes and also prepare hyperal and assess patients for nutritional status. That's what my job was. And, we were putting all this endoscopic tubes into patients to then start them in their enteral feedings. And I said, we had so many of this and we can look at outcomes. We should publish this. And at first, it leads to something that I learned later in life. John McGowan, who was a faculty member here, both in medicine and pathology, and who was a chief of microbiology down at Grady when I arrived here for residency, said something to me that I'll always remember, and I want people to know, which is if you don't publish it, it never happened. And I think when you have a series of patients, when you see a case, when you see, anything you do, having a scholarly approach in which you write it up and you publish it, I think it's important. And I learned that very early on. So, I started my residency, and I remember early on in my residency seeing, patients with HIV who also had tuberculosis and saying, well, TB ought to be a HIV indicator disease, an AIDS indicator disease. At that point, it wasn't. And my wife and I wrote a letter in JAMA saying, hey, we have all these patients at Grady who have HIV, have TB. There's got to be a link here. And now we know TB is a major cause of morbidity and mortality with people with HIV. So I think having an inquisitive mind and when you're seeing patients in the clinic, thinking about what you're learning and how you write it up and how you disseminate that knowledge is something that was put into my mind early on. I then started my fellowship in infectious disease, and in that sense, working, part of a fellowship was to work in somebody's lab, and a co-fellow with me, Bob Pinner, and I both wanted to work with David Stevens. And we wanted to work with David Stevens, who was a recent faculty here. He had just come here from Vanderbilt. And David was working on meningococcal disease and meningococci. And Bob Pinner and I went and and talked to David, and David said, I'll be happy to have you both working with me, but one is going to have to work on meninge, and the other one is going to have to work on gonococci, on GC. You have Neisseria meningitis, Neisseria gonococci, and most of his efforts were in meninge, but he was also doing some work in GC. And Bob and I left the meeting with David and said, what do we do? And we decided that we were going to flip a coin. And we flipped the coin, and Bob won, and Bob started to work on meninge, and his career has been defined by that. Bob then at the end of his fellowship, went to CDC, worked in the meningitis branch, and really has developed. And I went I got GC. I went into David's lab, started working in GC, started doing research there, and that eventually has influenced and it has impacted my life in this way that I got interested in sexually transmitted infections. So I think part of it is also luck.
That is how you got into sexually transmitted.
It's a flip of a coin, man. So. And then, why HIV? Well, early in my career, I tell people I came to Emory to do my residency because I wanted to be a cardiologist, and I wanted to work with J. Willis Hurst, who was then the chair of the Department of Medicine and one of the most famous cardiologists in the world. And when I had been here as a visiting student, I rotated with Willis, and I was very impressed with him and his teaching.
You're drawing vectors?
Oh, Mike, I can still do vector cardiography. I can still read EKGs, and I can have a little Willis in my shoulder telling me, how to think about the EKG and how to think about those vectors, right? So, but it was 83 when I started my residency, and there were all these patients coming in with this new disease, which ended up being HIV. And there were two things that were fascinating. Number one, there were people like me. They were my age. They were young men, many of them my age, my peers. But number two, it was a lot of science. I mean, almost every day there was something new. I still remember the day that at a lecture I heard about the first time that they said, well, this virus, it's a virus and it attaches to the CD4 receptor, and learning about the CD4 receptor and the lymphocyte. So the science excited me. And then in my second year residency, through some unusual circumstance, I ended up spending most of my second year residency at Hopkins. And at Hopkins, the chief of infectious disease was a man named John Bartlett. And I ended up working with John. And John really influenced my life, and I said, I want to do ID, and I want to do HIV. So it was a combination. I think mentors, I've been talking about the importance of mentors. Is John Bartlett, is David Stevens, is David Rimblin, is another person here, Sam Thompson. So those mentors were critically important in my interest in going into HIV, but also doing research and doing my scholarly work in HIV. At the end of my fellowship, I spent a year as chief resident at what is now Emory University Hospital Midtown. Back then was Crawford Lawn Hospital. And the chief of medicine there was Jack Schulman. And Jack, again, was an incredible, infectious disease physician, clinician, but also a wonderful mentor. And one of the things that was interesting at Midtown is there was an oncology clinic for underserved patients that was run by the residents and by Dan Carr, who was an oncologist in private practice. But the chief resident was responsible for the clinic. And out of that year as being responsible for that oncology clinic, where all of a sudden we're seeing a bunch of patients with lymphomas and HIV, I ended up actually writing, together with my wife again, 2 papers published in Cancer about lymphomas and HIV and looking at Epstein-Barr as a cause of it. So again, I'm going back to it's the clinic that informs your science that then translates into research.
And the clinical mentors that you had that actually influenced that direction. But you're talking about some of the giants, I guess, in Emory internal medicine over the past 20 or 30 years. There's a story I wanted to tell about Nanette Wenger had a birthday party, like her 90th birthday party, and there was a cake, and I believe you were at this party. And on the cake was an ECG, and it had, I don't know, it was a couple leads, but you were the only one who read that ECG, and read it correctly, actually. So those mentors had that long-lasting effect on you.
I mean, I always say that if I hadn't gotten into ID, I would have been a cardiologist. I mean, people like, Nanette Wenger, Bruce Logue, Willis Hurst, and I could go on, Bob Slant, that really influenced and really were, Steve Clements, for God's sake. Rounding with Steve was one of my privileges as a resident. So I think one thing that is amazing in our training is the kind of mentorship you have. And, I rounded with Danette as a medical student. I worked with her as a resident. And we know later on we were colleagues. But I continue to seek Danette's mentorship. And frequently she'll call me or text me or give me some advice on something. She always has something to say which is positive and which is inspiring.
Yeah, that is very true, and she's still doing it, I think.
And that's because she cares about people. And I think that's the other thing about mentorship. Mentorship is not just career advice. It's really caring about the individual.
So you were seeing these cases of HIV and AIDS, and you're ending up in your oncology clinic at Crawford. At the time, it was called Crawford Long, and you were a post-residency, post-fellowship senior resident. That's the way. That's the way it was done in those days, right? You don't have fourth year post-grads becoming chief resident.
Well, I did it for two reasons. I did it because my wife still had another year of training in her surgical pathology fellowship, so I needed something to do for a year. But also was a great opportunity of working with Jack Schulman. Again, being close to a very influential mentor.
And then you had to go back to Mexico for some period of time.
So I I initially wanted to, I had been, was getting more and more interested in HIV and realizing the public health implications. I realized that besides just taking care of the patients, it was to have an impact, you had to be at the population level. And so I applied to CDC. I wanted to join CDC, the EIS officer program.
That's the Epidemic Investigative Intelligence Service.
Yeah, and I got accepted, but because of my visa, I was not able to join EIS. So all of a sudden, at the end of my fellowship, I was faced with the decision: or do I, go and find a visa waiver somewhere in an underserved community, or do I go back to my country? And I made the decision to go back to my country for, I think, two major reasons. Number one is the opportunity to be back and be close to my family. We just had a 1-year-old, so that's an opportunity for the grandparents to be close to the grandchild. Number two was because, again, another influential mentor, Jaime Sepulveda, who had returned from Harvard where he got his PhD to Mexico, and he was the Undersecretary of Health. He said to me, you could be really helpful in helping us set up the HIV program in Mexico. So I landed in Mexico and quickly ended up working in public health with absolutely no training at all. It was literally, I remember when I got that offer, I said, okay, now I need to learn. I need to study public health. I need to get myself, educated in public health, because all of a sudden I was going to be in charge of public health for HIV in Mexico with no training. So again, it's taking opportunities and really taking them to the next level. And when I was director of the National AIDS Program, having mentors like Jaime and many others allowed me to see what we can do, not only to do a good program, but actually to integrate research into the program.
And how was that done?
Well, by asking questions, right? By asking, sometimes in public health they call that program evaluation, which is, okay, we do this interventions. Does it matter or doesn't? We are going to give people an HIV test. Do they take it or they don't? What's the characteristics of those that when we tell somebody they have HIV, do they come to clinic or they disappear? I mean, those are the kind of questions of program evaluation that then you turn into research questions, and pretty soon you are writing grants and you are doing research. And again, I was doing it with pretty much zero training and research. It's really learning on the job, right? But that's, in a way, that's how I learned to be a physician also. It was training on the job. That's what residency
Trial
is.
and error.
Well, it's residency's learning on the job, right? And I say that I had a
see one, do one, teach one? Is that
kind of approach, right? I mean, my first grant, honestly, I got a call from a friend who was the director of the HIV program at PAHO, who I incidentally had trained here at Emory in infectious disease, Dr. Fernando Zacharias. And he called me and said, hey, there's this great opportunity from the Rockefeller Foundation for a grant to look at HIV in high-risk populations in Latin America. You should write a grant. I'd never written a grant in my life. And I said, fine, but I have no idea what am I supposed to do? And he said, I have this friend who's at University of Washington, and he writes a lot of grants. His name is King Holmes. You should give him a call. So, this is before email. I got on the phone. I called King. He answered the phone. Fernando had introduced us. And this guy who was, again, another giant in the field said to me, who didn't know me, said to me, sure, come to Seattle. Let's spend a couple of weeks, and I'll help you write the grant. And I sat in his office, and, he followed his instructions and wrote a grant that was funded. So, again, talking about mentors, right? People that were willing to dedicate their time and effort to help you succeed. I think it's something that I have been very fortunate to have in my career.
I can attest to that experience as well, where you have a mentor who actually will sit down and help you with those things, necessary things that you don't necessarily know or have received training for previously. Grant writing is one of those things. So that grant was in Mexico?
That was a grant to look at essentially sort of risk factors for HIV among high-risk populations. We primarily were looking at sex workers. But it was, it was an epidemiological study, but that's when I started to learn how to set up a study and how to set up a big, survey and how to collect data and how to go through an IRB and all those things that are now part of research.
And there's a political aspect, though, to being an early HIV researcher, right? Or was there? Did you experience that? Or
there's always been, HIV has been always, been in the public opinion and been in politics, and HIV has always been very political. And I had to learn the politics of HIV and work on the politics of HIV and really realize how critical it was to have not only political support, but learn something that I think is very important, which we do a lot in HIV, which is advocacy, is how to use your voice to get things done. And also working with community. The other thing that I like about HIV is the fact that like in no other disease, maybe cancer a little bit, you work closely with the affected community. You work closely with those at risk, sometimes in not a very, I would say, cordial way, right? I mean, they're going to push you. They're going to challenge you. They're going to say you're not doing the right thing. But at the end of the day, that ability to work with community and that ability to do advocacy are two things in the HIV world and in my my research in particular that I really, really enjoy, is that combination of science, policy, advocacy, community that really makes the research very exciting and meaningful, quite a lot of fun, quite frankly.
And it's been the community-driven initiatives that have shaped the HIV AIDS programs that have developed over the years.
Without doubt. I mean, it's from ACT UP on. It's been community that has really gotten us to where we are in HIV. The fact that we have the drugs
ACT
we have.
UP being the early activist
Larry Kramer.
Program. Larry Kramer, yes.
Larry Kramer, ACT UP, and many others have been critically important to advance the HIV field, and they continue to be. In our Center for AIDS Research here, we have something called the Community Liaison Council, which are members of the community that work side by side with us in trying to advance the HIV research here at Emory.
I didn't know that. It's interesting. So at some point, you're moving into global health, the field of global health. Or are you, at this point, already in global health?
Well, in a way you are, because now I'm working in Mexico, right?
Yeah, okay.
So you can call it...
North American health.
Right, or international health, or whatever it is.
Yeah.
But I think pretty soon you realize that when you have a global pandemic, your research has to be global. And you start... I remember returning to Emory in 1996 to join the faculty, and one day Ken Walker saying, I'm doing a lot of work in the country of Georgia, and they have somebody working in HIV. You should connect with him. And I said, fine, I'll connect with this guy. His name was Tengiz Servatse. I would be honest with you, the first thing I did is I went to my office and looked at a map and said, where is the Republic of Georgia? I mean, I had no idea where it was, right? But by 1997, I was traveling there and developed a grant with them. We had a grant we applied for a grant with the World AIDS Foundation, and before we knew it, afterwards after that we had an NIH grant, and we started working with what has been now a 30-year collaboration with the country of Georgia in HIV, tuberculosis, hepatitis.
And so Ken Walker kind of paved the way for that, at least for that collaboration.
Absolutely,
right?
he just opened the door. He made the contact. You know, a lot of what you learn is this connectivity, right? It's that contact, it's that initial connection.
Yeah.
And I have done so many things through connections that other people have done. I'll give you another example. You know, again, sitting in clinic at the Ponce de Leon Center, the clinic that Grady has, I used to be there every Tuesday afternoon seeing patients, and I noticed one day, you know, one of the things that the attending of the day did, which was my job, was to sign the prescriptions that were brought in by the advanced practice providers, and especially for drugs like narcotics. And all of a sudden, I noticed that I was writing a lot of prescriptions, opioid prescriptions. And I called a friend of mine, which is Nora Volko, who's the director of the National Institute of Drug Abuse. And Nora is also Mexican. I've known her for a long time. I said, Nora, something is going on. I'm writing a lot of opioid prescriptions. And of course, the NIDA director said to me, you should write a grant. And I said, Nora, I'm not a substance use investigator. I have no credibility in that field. I'm an HIV investigator.
Yeah.
And she said, oh, yeah, but let me connect you with this other guy. So she connected me with somebody called Jeff Samad, who's a substance use investigator. And she got the two of us together. We wrote a grant, and we started studying opioid prescribing in our clinic, in his clinic in Boston and our clinic here in Atlanta, and doing an intervention to improve opioid prescribing. We started doing that way before the opioid crisis hit. But it was because I was in the clinic seeing this increase in prescriptions, and then Nora connected us, that all of a sudden I became a substance use investigator. So connections are so critically important. And sometimes it's not a mentor, but it's that influential person that can make that connection, right?
Yeah. It can make it easier, but can open more doors than you think you can open.
Absolutely. And again, but I emphasize to people that you have to always have an inquisitive mind. You have to ask questions. You have asking why. Why is this happening? Something strange is happening here. Is what distinguishes, I think, what I would say is a clinician from a clinician investigator.
That's very wise information. Because I'm thinking about this this sort of integration of your work, your research and public health, where you are. Is that kind of a correct assessment that you're sort of integrating a research component to your public health efforts?
Yeah, but I would say that my research has always been informed by what's happening in the clinic.
Yeah.
What you see in the clinic, I then take it into research by asking the questions. And then sometimes the way to answer the question is by doing a public health kind of intervention, right? Or a population-based kind of intervention. Sometimes it's doing a clinical trial.
Yeah.
Sometimes it's but again, when you finish the clinical trial, what's next? Well, in order to get the clinical trial results into population, you need to do the next step, which is how do you move this from, efficacy to effectiveness, right? How do you move to the individual level to the population level?
Which would be the ultimate goal for a global health approach to.
Which is what we all want. You want the discoveries that we have. To
medicine, right?
You want the discoveries that we have to not only improve the lives of individuals, but to improve population health.
So in the Emory community, there's been several people, right, including Ken Walker being an example, who, I mean, yourself and others who have done sort of global outreach, but not necessarily research, I guess. Like I'm thinking of Alan Dollar. Do you know Alan?
Oh, I know Alan very well.
So Alan, for many years would go to Ethiopia.
Yeah.
And his he would do some clinical work, but he would also educate. I guess he was a big educator.
So I think there's a spectrum, right? There's something called global medicine.
Yeah.
There's something called global health, and I think those are not necessarily the same.
Okay.
There's a lot of people at Emory that do global health research, and all the way from in the School of Medicine, people like my colleague Henry Blumberg or Russell Kemper or
Vince Marconi.
There's many others. There's people in the School of Public Health that do the same, but there's also people that are doing global medicine, and I think it's all part of an initiative. And the global component. What is really exciting is the relationships you develop and the colleagues you meet in other parts of the world, and you realize that we are all the same. We all have the same desires, the same aspirations. We want to improve the health of our patients, and in doing, therefore, a lot of us have also been involved in education, right?
Yeah.
And how do we develop new investigators? How do we develop better clinicians? But a lot of times we also learn from those places how to be better clinicians. It's just not just us doing something, but it's what they give us in return.
Don't go into it with your way or highway.
Oh, you have to go with two things. Number one, open eyes, willing to listen, but more importantly, a huge sense of humility. I remember, again, going back to advice, Warren Johnson, who was the chief of infectious disease at Cornell and a good colleague and mentor who's worked for many years in many parts of the world, including Haiti. I remember being with Warren one time in Tbilisi, in the country of Georgia, at an NIH meeting, and we were having coffee, and I said, Warren, let me ask you a question. I've been working here in Tbilisi for about a year now. You've been working in Haiti for 20 years. When will I know if I've been successful in what I do here? And he said to me, the moment they can write papers and grants without you as co-author or as co-investigator, you have been successful.
You've launched them.
And I said, that's great advice, right? That's an incredible piece of advice. You need to help them develop and be independent.
Yeah. Just like your mentors in your research group.
No different.
Or your mentees in your
Exactly.
research group. So I think in your career timeline right now, I'm not sure where we are. I think we've kind of jumped around a little bit, but I wanted to actually talk briefly about some of these big programs that you've been involved with. And I'm talking about the AIDS International Training and Research Program, the President's Emergency Plan for AIDS Relief, and then we talked a little bit about the Center for AIDS Research already. But how did these evolve? This series of programs.
So my AIDS International Training and Research Program was an NIH-funded program by the Fogarty Center. And again, it was the first NIH grants that I wrote and was successful when I joined the faculty here at Emory in 1996. I think I got that funding like in 1998. And
that was a new thing at the time?
There were programs in other places, but when the RFA came out, I responded to it, and I had as my target countries Mexico, Georgia, which I was working on, Vietnam, and I think those were the three countries.
Why Vietnam?
Well, it's interesting. Vietnam was because the CDC, through PEPFAR, has started a program in Vietnam, and colleagues at CDC said we really need a lot of help developing people in Vietnam. And I knew people at the School of Public Health in Vietnam in Hanoi, so that's why we put Vietnam into the program. But then in 1998, I'll talk a little bit about the CFAR grant. So 1997, I think it was, the RFA for the new applications for the CFAR, the Center for AIDS Research, came out from the NIH. And David Stevens, who was then the division director of infectious disease, said to me, well, you should write this grant. And this was a big grant. It was a P30, a program project grant. I'd never written anything like that. And I said, well, what do I need to do? He said, well, just go around Emory, talk to everybody that does HIV research. Here's a list. There used to be an HIV interest group among faculty. Go meet with each one of them and figure out what they do, and then we'll put a grant together. And I would say that David really put a lot of effort into helping us write that grant. And, he's not an HIV investigator, but he said, incredible grant writer, and he's, again, a very generous mentor. And he also came to the conclusion that the right person to be the PI for the grant was not me, but was Jim Kern, who was the dean of the School of Public Health.
Yeah.
Jim had just started here, but Jim is
he was originally from the CDC.
But he was a big name in HIV, right?
Yeah, yeah.
So it made sense for him to be the PI. And I remember one day getting a call from the chair of the Department of Medicine, who said to me, "I understand you're writing a big, program project grant." And I said, "Yes." He says, "And I understand that the PI is going to be the dean of the School of Public Health." And I said, "Yes." He says, "Well, you can't do that. You can't write that grant. It needs to be in the Department of Medicine." So I was very concerned. I went and called David. I said, "David, what do I do?" He said, "Don't worry. I'll deal with the German. You write the grant. In order for us to be successful, Jim is the right strategy." And I say this because, again, David was very thoughtful about what was the right strategy to get the grant to Emory. And we did. We were successful. We got the grant to Emory, and we've been funded for the last 25 years. So, when we started that grant, we had less than $10 million of HIV research, NIH money, and NIH dollars of HIV research here at Emory. Last fiscal year, we had $72 million of NIH funding and in HIV here at Emory. I mean, the way we've grown HIV research here at Emory as a consequence of having a CFAR here has really been incredible, and has been one of the things that I feel most proud of. Emory now is really known as one of the leaders in HIV research because of the people we've been able to recruit as a consequence of having a CFAR. People like, Guido Silvestri, people like, Mirko Paiardini. I can go on and on about incredible recruits we've brought to Emory because we have a
Shinazi
CFAR.
was where he was already here.
He was already here.
Yeah.
But, Ray was doing his thing. He was doing his medicines.
Yeah.
But Ray has also been very supportive of the CFAR efforts. I mean, Ray has been really a huge champion that has allowed us to build a drug discovery program within our CFAR and many other things.
We're talking about Ray Shinazi, who is the inventor of AZT.
No, actually not AZT. Ray Shinazi and Dennis Liotta invented, many medicines, but the two most important ones in HIV are one called lamivudine, also known as 3-TC, and one called emtricitabine. Emtricitabine is the most successful one. Emtricitabine is the most common. More than 90% of the people globally with HIV medicines are taking emtricitabine. And what I remind people, the name emtricitabine, the EM of emtricitabine is Emory.
Oh.
EM, and the trade name of the drug is Emtriva.
Yeah.
EM is Emory.
Yeah.
Tri is Trimeris, because that's the company that Ray spun to produce the drug. And VA is the VA because Dre's lab
was at the VA.
Was at the VA.
Yeah.
So Emtriva, but the most commonly used HIV drug, emtricitabine or Emtriva, the first two letters are Emory.
Okay.
That is
a not a well-known fact, I don't believe.
Well, it should be. It's the most important. It's the most important contribution of Emory. To human health.
That's a pretty bold statement.
It's without doubt. I mean, you got to think that currently globally in HIV therapy, there are about 30 million people receiving HIV medicines. They're receiving a combination of three drugs.
Yeah.
Dolutegravir, tenofovir, and emtricitabine. That means 30 million people globally are taking a drug that says Emory on them. Yeah. Okay? Just think about that. 30 million people are alive because of a drug developed here at Emory by Ray Shinazi, Dennis Liotta, and others.
And it's helped build some buildings here, I believe. Right?
Oh, there's no doubt about
that. So just to go back a little bit here, so the PEPFAR, is that how you say that?
So PEPFAR
that kind of predated the CFAR.
That's actually later.
Oh, it's later.
PEPFAR starts in 2003.
This is the President's Emergency Plan for AIDS Relief.
Yeah, it's during the George W. Bush administration, and George W. Bush, working together with people like Colin Powell, who was the Secretary of State, and Tony Fauci, and many others, they decide that it's really important to develop a global HIV program and get therapy to people globally. This is the first time that people think about getting drugs to people outside the U.S. And they say, and they realize it's important for three reasons. Number one, AIDS was really killing millions of people globally, but particularly in sub-Saharan Africa. young people. So the global burden of disease, the number of young people that
Yeah.
were dying, was incredibly high. So the expected life expectancy was dropping, and many things were happening. Number two, when you lose young people in a population, you have the risk of civil unrest, you have the risk of civil war and other things. But number three, you also have economic stagnation and poverty. So there were reasons of diplomacy, of defense, and of development, the three big Ds of global health,
Yeah.
of why we needed to do this. And that's why Colin Powell, who was the Secretary of State,
He recognizes.
he recognized this and really pushed for this. And in 2003, at the State of the Union, President Bush announced the creation of this program, PEPFAR. And at that point in time, the big goal was to get 3 million people on therapy by 2005. It was known as a 3x5 initiative. And most of us thought that would be impossible. How are we going to get from 0 to 3 million people on therapy in just 2 years? But it was a huge effort by the U.S. and many other countries and local leaders and many others that not only made us get there. As I said to you, as of this year, we don't have 3 million people on therapy. We have 30 million people on therapy. Nobody would have ever imagined that would be the case.
And the strategies that were used to do that have long-lasting impacts.
They have huge impact because they have not only developed infrastructure to take care of patients, they have also developed lab infrastructure, they have developed people, they have invested in supply chain, they have developed many other things. And the result of that, a good example of that is when COVID hit, all of a sudden we had the infrastructure to take care of people. We had the infrastructure to do testing, right? The reasons there are PCR machines throughout Africa is because of PEPFAR. And as a result of that, you can use those PCR machines now to do COVID testing and many other things.
Yeah.
So that infrastructure has paid off, benefiting many other things.
So that's a little bit of a segue into a question I had for you about sort of parallels between the HIV/AIDS epidemic and the COVID-19 pandemic, with a swine flu in between there, right? Are there parallels here that we're seeing, or
well, the first,
are they totally different?
The first thing is that in infectious disease, there's always emerging diseases, right? There's always something new emerging, whether it's HIV or swine flu or COVID or monkeypox or mpox or you name it. Now there's avian, and now there's bird flu. There's always something that is emerging, and I think
something in Congo now, right?
There's
Republic
Marburg,
of Congo.
There's Marburg. There's always something that is emerging, and the emerging infectious diseases are occurring for many reasons. But number one is climate change.
Yeah.
Number two is changes into humans are now entering areas that were normally not inhabited, forest deforestation, etc. And number three is population growth and travel, right? If somebody is diagnosed with Ebola in Liberia today,
they can go to San Francisco tomorrow.
Correct, which didn't happen before, right?
Yeah.
So we're all, borders mean nothing when you're talking about infectious disease. Bugs don't really care if you have a border. We saw COVID emerge in China, and within weeks, within months, we had it in our country. We had it globally. We saw our patients here at Emory. So I think that's one thing that you learn is that in infectious disease, we can't talk about countries. We're all interconnected. We're all part of a global community.
And the strategies that you developed as part of your the PEPFAR, those are applicable to, you already talked about this a lot, but you talked about the infrastructure.
I mean, PEPFAR has developed many things: infrastructure, capacity building, clinical capacity. But I think the most important thing that it has done, it has shown us that the impossible is possible, right? That you can do things that you didn't think you could do. If you have two very important things: community support and political will. And I think when you think about COVID, if we hadn't had the political will, President Trump deciding to launch Operation Warp Speed, and we hadn't had the scientific infrastructure, and we hadn't had the community support, we would not have had a COVID vaccine developed so quickly. So I think science, policy, politics, community working together can turn the impossible to possible.
So that's very optimistic. Like, we're getting better at it.
But
we got better from HIV/AIDS to COVID.
Yes, but it's also very fragile, right? Because you're bringing together, different people that don't necessarily know how to talk to each other. So I think one of the things that we need to learn as scientists is how to better communicate to the people, how to better communicate to politicians, how to better do this dance. And when people talk about mistrust in science, I mean, we all need to work to make that better. It's not going to happen automatically. We need to get the community to understand the value of science. We need to get the politicians to understand the value of science. And we need to work together because at the end of the day, in medicine, we frequently say, let's put the patient at the center. Well, let's put the individual at the center in order to improve the health of the individual. If somebody's dying of a disease, whether it's HIV or COVID or diabetes, what can we do together, politicians, scientists, community, and the fourth partner in that is industry, right? How can the four of us work together to really change that and to really improve the situation?
So that's a good segue into communicating. And you are a master communicator. You've been on multiple broadcasts. What is your goal in that effort? What do you see yourself as?
Well, first of all, let me start by saying that I started diving into communication when I was in Mexico as director of the National AIDS Program because, I had to do it. So I learned a little bit there. But really my in-depth, I would say my in-depth training in communication really happened in 2006, 2007 when Grady was having a big financial crisis. And Tom Lawley called me and said, we need you to be the spokesperson for Emory at Grady. We need you to help communicate to the people the importance of Grady and why we need to support Grady. And he literally sent me to communication school. He sent me to a 3-day training.
When was this?
2006, 2007. He literally sent me to a 3-day training, intensive training.
This is when Grady was kind of financially
very unstable. On the brink of closing.
Yeah.
And Tom Lawley said, we need you to be out there, but we want to train you on this.
And you were the chief of
medicine
at Grady at the time. Okay.
And there was no such thing as a dean for Grady, so it was really me.
Yeah.
And he, and that training that I received was really important because literally I went to a place that trains communication experts at CNN and other places, and they would have me do an interview with somebody. They would tape it, and then I would go into a room and they would destroy me, right? They would tell me what I had done wrong and what could I do better and what had I said. And, I learned a lot about communication there.
Yeah.
So communication is such an important tool. And just because you can speak at a scientific meeting or you can present an abstract, that doesn't make you a good communicator. When you're talking about speaking to the press, when you're talking about speaking in radio and television, it's about simple, short, concise messages. And it's about the story, right? What you learn is it's a lot about telling a story, telling a compelling case for something, telling the public that we are very important and we save millions of lives. Doesn't matter. They want to hear a story. So It's about storytelling. It's about taking your science and turning it into an individual example, turning it into ways in which people can relate, in which it means something to you, to your family, to your neighbor, to your community. And that's what a good communicator does. It really is bringing our discoveries into a way that it makes sense to you.
And so a media outlet will call you and ask for your comments on COVID-19, and you say, "I'm happy to do this." Is this something that you seek out, or is this something that?
Well,
do you really enjoy doing this? I guess is the question I'm saying.
I enjoy doing it. I enjoy doing it, but I also think it's critically important. I mean, I would say that to me during COVID, it was particularly frustrating when we're talking about infectious disease, something like COVID, to have people who were nutritionists or cardiologists, for that matter, in television talking about COVID. I mean, what do they know about it? We needed experts in the field to talk about it. And I figured as an infectious disease physician and a public health expert, I had an obligation to help inform the public. And there's nothing more important of that informing and communicating at a time of crisis. And during that crisis, communication is such a critical component of decreasing the anxiety individuals have.
Did you find that communicating during your previous work, the HIV, in your previous communications with concerning HIV and AIDS, different from when this COVID pandemic hit?
I don't think so that much. I think the only difference is, with COVID, the combination of the speed of the transmission of the disease and the ability of 24-hour news coverage and social media made the communication just happen so much quicker. I mean, you and I are old enough. It's like going from 33 records to 78 records. They were just going so much faster, right? And I think that's the issue. The issue is that with COVID, you could not tell a reporter, okay, I'll call you tomorrow. They need an answer right now. They want to talk to you in the next 2 hours in order to write their story. The TV wanted to hear you tonight. They didn't want to hear you tomorrow. So the way in which you had to react and respond had to be very quick. And therefore, I would be sometimes at television 3 or 4 times a day. And sometimes would be at 2 a.m. speaking to CNN International. And sometimes it would be at 7 a.m. speaking to, Good Morning America. It was really like, it was literally, my schedule was filled with media hits, media, because, and I could go to work in the morning and know nothing. And by, 10 in the morning, I had 5 media interviews that was on lineup.
What about politically, though? Was it different?
Again,
I mean, you know what I mean by politically, right?
Yeah. Again, it is different, but it's also the same. HIV is political. I think what happened is that with COVID, one thing that happened, public health has always been political. Public health has not necessarily been partisan.
Yeah.
And with COVID, public health became partisan. And I think that made it hard. When public health becomes partisan, then it's an issue, right? When wearing a mask or not wearing a mask is the difference between you being Democrat or Republican, that really doesn't make any sense. But that was the reality. We were seeing that, and I think that the partisanship was difficult to deal with and continues to be difficult to deal with, because I don't want to, when I speak about public health, when I speak about science, I don't want to be political. I want to be scientific.
Yes, objective.
I want to be objective, right? But the reporters want you to talk about the politics.
Yeah.
And that makes it really hard.
So you get baited a bit here.
Correct.
So it's a minefield. You're kind of tiptoeing through a minefield at some point.
Well, you also have to know how to respond to a reporter, right? A reporter may want you to say something, but you have to stay on message. You have to really steer yourself into, as much as you're being tempted, not stepping outside the boundaries.
There's the Carlos del Rio communicator, and then there is, say, the Surgeon General from Florida communicator. And so one tells you that you need to get vaccinated, and the other one says vaccines don't work. How do you deal with that?
Well, remember, again, my goal is hopefully not to be partisan, not to be political, but to present people with the facts and the evidence. The Surgeon General of Florida may have a political agenda. He has a political position. He's a political appointee, and as such, he has to defend a certain political inclination, right? So, again, my job is not to attack him as an individual or what he says, is to present the data, to present the facts. And when he says, well, vaccines don't work, I can talk about the reasons why, the evidence of why vaccines work and why vaccination is an important strategy. I don't need to attack an individual. I need to simply present the data and the findings and again, present the story that makes it compelling to somebody. I'll frequently tell the story about, my father growing up in the 1920s and 1930s telling me about how horrible polio was, how, you would come back from summer vacation and 3 of your classmates were not there anymore because they had gotten polio and now they were in the hospital or they were in iron lungs or they had died. And how when polio vaccination was developed by Salk and others, Sabin and Salk, all of a sudden that didn't happen. It was amazing, right? And
kids are going back to school.
And you can go back and you can be assured that you return to school after the summer break and not and 3 of your classmates will still be there.
Yeah.
So I think, the clear evidence that polio vaccination changed the life of children. And I think telling those stories is really important. And I think one thing we forget is, the problem with public health is when public health is at its best, is silent. You don't see it. So people say, well, why do we need vaccines if we don't see polio? Well, it's because we have vaccines. So you have to be able to tell the stories, remind people of the value of things like vaccines in order for them not to forget why we need to continue doing this kind of interventions.
Yeah, I mean, that is, I think that's really great advice. But the other thing I'm thinking of now is that the anti-vaxxers also have stories, right? So
there's no doubt.
There's stories.
There's no doubt.
And the lay public has to sort out what is a real story and what is not a real story.
Well, and again, I'll give you this example, right? I was traveling and I was in a flight and I was sitting next to a person, and it turns out this person is a social media influencer, somebody in their late 20s, early 30s, and has millions of followers. And we were talking to he pretty soon, I had an Emory jacket, so he asked me what I did. I said to infectious disease, and we started talking. He asked me about COVID vaccines, and he told me about the fact that his sister had died after COVID vaccination. And I said, well, how do you know? I mean, what happened? This is very unusual.
Yeah.
I mean, I was part of the study that led to the approval of the Moderna vaccine, and that didn't happen. So I want to understand. He said, well, my sister
You told him that? You told him you were part of this?
Yeah. My sister went and got vaccinated, and then that evening she died of a pulmonary embolus. And, when you start hearing more, it turns out his sister was overweight. She was taking birth control pills. She had many other reasons.
She had another reason to have a PE.
Yeah. The fact that she got a COVID vaccine was just incidental and coincidental, but it wasn't. I mean, association is not causation, right? But I tried to explain to him that, but simply he was stuck in this COVID vaccine killed my sister, therefore I don't recommend it. And I was trying to explain why he was wrong. And I think he listened to me.
Yeah.
I'm not sure if I changed his mind, but we had a polite discussion about it. And I think that's what we need. We need to learn how to disagree on issues, and then let people make their own decisions. But the reality is, when the anti-vaccine movement says, well, vaccines cause autism, well, I think the scientific evidence is overwhelming, and I could put multiple examples, but the one example I put all the time is a colleague and good friend, Peter Hotez, who's a vaccinologist.
Also on the media a lot.
Yeah, but Peter has a kid with autism.
Yeah.
And Peter wrote a book that is called something like Why Vaccines Didn't Cause Rachel's Autism. I mean, he really gets his personal story of his daughter with autism and goes deep into the science of explaining why the vaccines he gave his daughter had nothing to do with the autism. And I admire somebody like Peter who can do this because, Peter has been a target of the anti-vaccine movement because of how forcefully he defends vaccines. But the reality is that's what we need to do. In a way, you become, I won't say you become a martyr, but you have to stand to your principles, and you have to be very clear that there's a truth and there's things that are not the truth. And you know, our job is to stick to the science, to stick to the facts, to stick to the data, and to reinforce them and really make a point. Around COVID vaccines, what I told this individual, I said, look, the most vaccinated group of all the people, all the professions, are physicians. Do you think we would be the most vaccinated group if we truly knew there was something wrong with the vaccine? I mean, we got the data. I was part of the study. I've seen the true data. Do you think I would have allowed my kids and my wife and my family to be vaccinated if I thought this was risky? Of course not, right?
Yeah, that fact doesn't get publicized too much, I guess.
But we need to
But
talk
it's
about
important. It's very important. Yeah. Okay, I think we're gonna go into our final segment of our podcast today. We call it Do or Don't, and in particular, I guess sort of in the same vein of the conversation we're having now about going into a world, starting a career in a world where there's a lot of science denial. What kind of advice you would give to the next generation of leaders aspiring to global health? But in particular, we ask, what did you do earlier in your career that you would advise others to do? And I think we've got a good sense of that already, but maybe you want to comment on that further. And then the flip side of that is, what did you do early in your career that you would advise others not to do, early career investigators not to do, with a focus on sort of global health?
Well, the first thing we talked about is be inquisitive. Have an open mind, be inquisitive, ask the why questions. Number two is seek mentors. I mean, I cannot overemphasize the importance of mentors in a successful career. I think number three is don't be afraid to fail. All of us have written grants. We always talk about our successes, but we rarely talk about our failures. And we've all written grants that have been rejected. We've all written papers that have been rejected. So don't be afraid of failure. We come into the field of medicine as successful individuals. We don't know how to fail. We've always been good in school. We've always got great grades. And I think learning how to fail and stand up and try again I think is very important. And my fourth advice is seek colleagues and collaborations, right? Science is a team sport. And the more you work with others locally and globally, the more you develop a network of collaborators, I think the more fun you would have. Because quite frankly, your science will be better, your studies will be better. But more importantly, you develop long-lasting relationships. I mean, I have a colleague who I first met many years ago doing a CDC study, Lisa Metch at the University of Miami. Now she's at Columbia. We continue to collaborate. We were, in fact, today finishing a paper we're writing together. We've been colleagues and collaborators for 20 years. We've gotten, 3 R01s together. And that collaboration has been incredibly successful as a result of the fact that our expertise is complementary. She's a sociologist, I'm an infectious physician, and yet we've worked together in a very effective way. So I think that collaborations and networks are very important. Things I would advise people not to do is, when there's something that you've seen and you discover, and you don't delay writing it, don't procrastinate, because we've all been procrastinators.
Yeah.
And I mean, I can think about something. For example, I gave a presentation at one of our major meetings many years ago on something that I said, well, here's the number of people that have HIV, here's the number of people that get tested, the number of people that go into care, et cetera. Because people were saying, well, you find everybody's infected and you treat them and we're going to end this epidemic. And I showed this data about how this numbers got smaller and smaller. And after that meeting, I wrote it up. I sent it to a journal, got rejected. I said, I just put it aside, didn't do it. And then, several years later, I was doing a visiting professor at University of Colorado in Denver, and one of the investigators there said, oh, let me show you this paper I'm putting together. It was essentially what I had talked about. And he said, we want you to be co-author because you were the inspiration for this work we're doing. I said, absolutely, I'm happy to work with you, Dr. Gardner. And, And that paper got published with him as the first author, and I was sort of a middle author. And that paper is something that we call now the cascade of care of HIV, and people recognize, Dr. Gardner as the one that developed this, when in fact I had developed it before, but I procrastinated and didn't push and didn't send it to another journal and didn't send it to another journal.
You didn't persist.
The persistence is very important.
Yeah.
So and then the other advice I have for people, and I think I've talked about this, is don't be afraid to write things. We as I always say that the best predictor of success in an academic career is your ability to write. Get comfortable writing, and it could be case reports, it could be piece of minds, it could be opinion pieces, but get comfortable writing. Writing is the currency of academia, and I think if you want to be in academic medicine, you need to be a good writer.
Very profound. Pen to paper is usually the hardest step, though, right, in your academic.
Absolutely.
Getting pen to paper.
So
you can go out and look at data and interpret data, but getting the pen to paper, writing the grant or writing the paper is the hardest thing to do.
So Ernest Hemingway used to, there's a restaurant in Decatur called the White Bull.
Yeah.
And the White Bull actually is something that Hemingway talked about. And he called the White Bull the blank sheet of paper. It is that terrifying thought.
Yeah.
That is, Hemingway talked about bulls in Spain.
Yeah.
Well, the White Bull is that blank sheet of paper is terrifying, that you have to start writing. And what I tell people, we talk about pen to paper, but now it's in your computer.
Yeah, right.
Just start
typing.
Start typing. Don't worry about it.
Yeah.
Just type some ideas. And a great writer with really good advice has been my wife, Dr. Jeanette Warner, who's a professor of pathology and vice chair in the Department of Pathology. She has some great advice about writing. And she says, just write, don't stop, write, and then after a few, paragraphs, put it away. Don't try to edit it. Don't try to correct it. Then you come back. But writing in chunks and in pieces, and don't try to start from start to finish. I tell people, start with the results because sometimes that's what you have, and then write the methods. But you don't need to start with the introduction. And there's just different techniques, but get comfortable writing, and don't be afraid of, I'm not a native English speaking. I can tell you that writing in English used to be, when I first started writing, it was hard. Now it's actually hard to me to write in Spanish, to tell you the truth. When I the other day I was asked to write a paper in Spanish. It's really hard because I'm more comfortable now writing.
Muscle memory there?
The muscle memory goes away. But develop it. That writing is such an important skill, and it's such a critical job of us in academia is to write things, whether it's a book chapter, a case report, whatever.
But we write clinical notes too, right?
But scientific writing is different. I love to go back to, in the 1940s, there's a paper, Gene Stead described what we now call hepatitis C, post-transfusion hepatitis, and he described it at Grady. And he wrote a paper in JAMA that he's the only author. And you read this paper, and it's like an essay. It's like this beautiful 12-page paper in which he describes literally, I got up and I went to the wards. And the way we write a paper in JAMA today is very different, right?
Yeah.
I think you need to also learn how to write. And having done creative writing in college, unfortunately, it doesn't help you to write a piece of JAMA or in New England Journal of Medicine today because writing is very different. So you need to also get comfortable writing that. And then there's, of course, grant writing. Grant writing is another different language, right?
Yes, that's...
So we all need to be taught how to do that, but my advice is don't be afraid to do it.
Okay. What do you like to do in your spare time when you're not writing grants or papers?
So I like to do
or leading a department of medicine.
I like to do a lot of things. I like to travel. I like to spend time with family. I love to eat food and go to restaurants and experience new foods and I love to drink wine and collect wines and learn about not only just the wine but where the wines comes from and how the earth there is and how the grapes are and what the family does, and so learn about that. And
you don't make wine, do you?
I don't make wine, but
there's a label I have. There's a bottle of wine with a label on it.
Yeah, but that's not my wine. It's just a coincidence.
I was like, does he have a vineyard in Oregon or something?
It's just a coincidence. But I like that as a Christmas present, just to show that I have this love for wine. But the other thing I like is I'm a big fan and supporter of the arts. I'm in the board of the Atlanta Symphony, and
Nice.
and I'm in the board of the Atlanta Opera, and I spend a lot of time working with the symphony and the opera and a variety of things. And to tell you the truth, one of the most gratifying things during COVID, and I think one of the things that kept me going during COVID, was the ability to work with the Atlanta Symphony and the Atlanta Opera to keep them going during the pandemic and keep them able to perform during a time that, I mean, the Atlanta Opera was the only opera company in the world that did not stop as a result of COVID. We continued to operate, and it was because of the mitigation efforts that I did with them to allow them to do that. And now the Atlanta Opera is one of the most successful, it's a top 10 opera company in the United States, in great part because not only did we survive COVID, we thrived during COVID. The Atlanta Symphony was able to continue working and has developed new audiences as a result of COVID. So I also like that kind of stuff. I like to be creative and thinking about ways in which we can overcome adversity and find ways about, rather than saying no, trying to figure out how can we still do this and what are the steps we need to take. And it may be complicated, but at the end of the day, if you're able to do that, I find that very creative and enjoy that.
That's very public healthy, isn't it?
Yeah.
It's kind of like applying public health to music, I guess.
Oh, totally. But at the same time, it's very rewarding. You know, it's the fact that, as I said, I think, I find music particularly rewarding and important in my life, and I think being able to work with musical institutions to do that during COVID was very rewarding.
So you like classical and opera,
but I also like jazz.
Okay.
I'm into.
You know what's coming, right? We're going to ask you for 3 songs that you want to contribute to the Research Ride playlist.
3 songs that I like to contribute to.
Do you have?
Well, I mean, Elton John has been a friend.
Yeah.
For many years,
former Atlanta resident.
Correct, but because of HIV, we've known each other, and his partner and I are good friends. So I have to put a
Elton John
song at the very top, right?
Okay.
And there are many of his songs that I absolutely love, but I think Rocket Man is clearly one of my favorites.
Nice.
but there are many others. Goodbye Yellow Brick Road.
Yeah.
I could go on and on.
Yeah.
But Rocket Man is clearly one of my favorites.
Okay. Any others you want to?
Well, I would go into jazz, and probably Louis Armstrong being also it's very important and significant. But I think if I think about a song that I be good in the podcast, It's a Wonderful World, just because it's the science and research is a wonderful world. We're very privileged to be in medicine.
Wow.
And medicine is a wonderful world. So I would put that as a third one. And then as I said, I'm a big fan of classical music and of opera, and there's some amazing some amazing opera arias that I love.
Yeah.
But there's an opera called Gianni Schicchi, which I think I like a lot, and there's a song there, it's an aria called O mio bambino caro, which I think is wonderful. There's also, of course, Maria Callas made famous in the movie Philadelphia, which is a link to HIV, an aria called La Mamma è Morta that is played during the movie and is just incredibly moving.
Yeah.
And of course, an old-time favorite of everybody, but mine in particular is in classical music. Of course, is anything Beethoven-wise, and Beethoven's Ninth Symphony would clearly be the highlight.
Yeah.
but there's a Mexican composer, Moncayo, who wrote a piece called the Wapango, which is fantastic, and I would add Wapango to this, and I would say that during the I'll send it to you, but during COVID, I used to have this town hall meetings, and in which I informed people at Emory and in the community about what was going on.
Yeah.
And at the end of those town hall meetings, I always had a musical moment, and a good friend of mine, Carlos Prieto, who was at that point in time the director of the National Symphony in Mexico, and now is the director of the Chapel Hill, the North Carolina Symphony Orchestra. I called him and said, "Can you guys play Wapango for me to play?" And he dedicated that performance of Wapango to the Emory physicians and nurses and healthcare workers. So I'll send you a link to that so you can see it, because it's really very good.
They played it in an audience?
No. You'll see it how they played it. Each one played it in their own room, and he put it all together.
I think I saw that.
It's absolutely amazing.
I think I saw that, actually.
So I would say that again, during those town hall meetings, I used to bring music as a way to make people feel, energized and make people feel like they were being supported.
Well, that's great contributions to our playlist. I appreciate that. Thank you so much. So we're going to wrap it up here. And we want to thank you so much, Dr. Del Rio, for joining us today in our podcast studio and our research ride. And I also like to thank the listeners for joining us for another episode of this podcast. This has been your ride leader, Charlie Searles. And the producers of this podcast are Sarah McClellan, who is also our studio engineer. Hey, Sarah.
Hi.
And Ben Searles, who he's the other podcast editor. And the theme music is composed by Hannah Searles. So thanks again, and we'll see you next time.